Now let's move on to our last Clostridia species, Clostridium difficile. Now this one's a major one as well. All the Clostridia species are pretty important, but this is the one you'll most commonly see. So you have two important toxins here. Toxin A, which is an enterotoxin, which binds to the brush border of the gut and triggers apoptosis, cell damage to the epithelial cells, and also you lose the tight junction, so you end up getting more permeability and loss of water and inflammation. So it damages the intestinal cells, causes more fluid loss and secretion, leading to diarrhea and inflammation. Now, toxin B is even more potent than toxin A, and it's a cytotoxin, so it kills cells very rapidly. It causes depolymerization of actin, which is an important component of the cytoskeleton, and that causes major colonic necrosis and a pseudomembrane forms, as well as diarrhea. That's why it's called pseudomembranous colitis. So it's usually secondary to antibiotic use. If you use broad-spectrum antibiotics, you kill off your normal flora in your GI tract, and now Clostridium difficile, which normally lives there, is going to grow because it doesn't have as much competition with other bacteria. So the classic, you need to memorize this 100%. The classic things that are associated with C. diff are clindamycin, penicillins, cephalosporins, and fluoroquinolones. Know this. If you see a case with any of these drugs and you have diarrhea showing up, you should think of Clostridium difficile diarrhea. So C. diff colonizes the intestines after alteration of normal GI flora by these antibiotics. So how do you manage these patients? The first thing, obviously, is to stop all antibiotics ASAP. You do not want these patients to be taking antibiotics. That's going to kill the normal flora, which is actually helping you against the C. diff. So except for C. diff treatment, stop all the antibiotics. Contact precautions are necessary also. You don't want to spread this to other people and other patients, especially because they're spore-forming bacteria. So you need to use soap and water so you can get rid of the spores. Do not use alcohol. Alcohol does not kill the spores, so you cannot use hand sanitizer. You need soap and water to wash off the spores. So what are some indications for treatment? If you have symptoms, diarrhea, abdominal pain, vomiting, which are caused by the cytotoxin and the enterotoxin, and a positive C. diff PCR for the toxin, that's when you treat these patients. So the toxin is positive without symptoms, you don't need to do anything. It's asymptomatic colonization by C. diff. Mild versus severe disease. This is where it gets important. Indications of severity are a high fever, if you have a high white cell count, or if you have low albumin, and creatinine greater than 1.5 times the baseline. What they normally have, 1.5 times higher. So if you have any of these, that's a sign of severe disease, and you need to treat it accordingly. If none of these are present, it's a mild disease. When you do surgery for these patients, you do it if it's a very severe condition, such as toxic megacolon, perforation. If you have such destruction to your colon that the colon actually perforates and you get peritonitis, that's a major problem. And rapidly progressive disease with systemic symptoms like hypotension, tachycardia. What is toxic megacolon? That means that your intestines, colon, is dilating massively, leading to fever and cytokine release, and it has a high risk of perforation and may require surgery. So what are some symptoms of some Clostridium difficile diseases? So we first have diarrhea with colitis. This is usually after antibiotics, you get this diarrhea. And can it happen in kids? Yes, it can. Actually, on my step 3, I had a case in a CCS where you had a kid that had diarrhea with Clostridium difficile. So it's something you should know. You get watery diarrhea, more than 3 stools in 24 hours. Lower abdominal pain and cramping, which is commonly associated with diarrhea. And you have increased white blood cell count, increased creatinine, and fever. So if you have very high of these, it's a severe form. If it's mild elevations, it's a mild form. How are we going to diagnose it? Like we said, C. diff PCR is very nice to detect the toxin and can help us. But the problem is it cannot differentiate between asymptomatic carriage and infection. Remember, if it's asymptomatic, you don't treat. You need symptoms to trigger treatment. Endoscopy is usually not necessary, but there are some classic findings you might get in a case. You have pseudomembranes, which means you have scattered yellow to off-white plaques all over the colonic mucosa. They're scattered everywhere. So it's not a diffuse whole pseudomembrane. Usually it's multiple plaques of pseudomembranes. How are we going to treat? There's multiple ways to treat this disease. If you're the first time you have it and it's mild, you give oral metronidazole. If it's severe with any of those criteria, you give oral vancomycin. Why not IV vancomycin? Yeah, IV vancomycin does not have a lot of bioavailability inside the GI tract. So only oral vancomycin will because it does not get absorbed very well. So vancomycin will stay in the GI tract and kill the Clostridium difficile. What if you have recurrent mild disease? You give oral metronidazole for that. Okay? If it's recurrent and mild, then you give oral metronidazole. But a key differentiating factor is if the disease never resolves, say they have Clostridium difficile colitis and they have diarrhea despite oral metronidazole therapy and never fully cleared it, you need to move on to oral vancomycin or even fidaxomicin. So it's recurrent and severe, give oral vancomycin or oral fidaxomicin, another antibiotic. And if you have multiple recurrences, definitely give oral fidaxomicin and even consider a fecal transplant. Why would you do a fecal transplant? That sounds very strange, huh? The reason why is that the fecal transplant will give you more bacteria, and these bacteria will compete with the C. diff and bring down the numbers of C. diff. It's like having a little army of mercenaries coming into your body. Now the fulminant colitis is where it gets really bad. This is where C. diff takes over and causes massive problems, usually in an immunocompromised patient or someone with some kind of predisposition. And what kind of symptoms do you get? It starts out pretty similarly with diarrhea and cramping and also diffuse abdominal pain, but that's when it gets worse. You get fever and lactic acidosis due to decreased blood supply to your body and your organs. Hypoalbuminemia, increased creatinine and increased white blood cell count. Increased creatinine due to dehydration and hypotension, so you lose GFR. And it can also present with ileus. Ileus means you have decreased tone of your GI tract, so it's fully dilated and not tonic. So you have very decreased bowel sounds, and the colon and the small intestine are not moving. So there's no peristalsis. You can also get systemic toxicity. You can get hemodynamic instability with hypotension, toxic megacolon, bowel perforation, and even renal failure. So all of these are major indicators of systemic toxicity and major problems. So if you have hemodynamic instability, you need to stabilize the patient because this is getting very fulminant. Toxic megacolon is a sign of fulminant colitis, perforation, and also renal failure. Renal failure due to the dehydration and the hypotension causing elevated GFR. What are some signs of peritonitis? The two classic ones are rebound tenderness and involuntary guarding. So if you see either of those two, suspect peritonitis in these patients. How are you going to manage these patients with fulminant colitis? If they're crashing, like they're hypotensive and they're falling apart, you need to stabilize them first. Always stabilize them using the ABCs, airway, breathing, circulation. Then image them to find out exactly what's going on and get an immediate surgical consult. Imaging can help tell you if there's free air or how big the colon is dilated. Now, how are we going to diagnose it? Systemic toxicity, as we said before, and colonic dilation on imaging of greater than 7 centimeters. So this is how you diagnose it. If it's fulminant, you're going to have massive colonic dilation. Preferred method of imaging to detect the colonic dilation is a CT scan. Now, treatment. How are we going to treat this? We need surgical treatment to get rid of this affected bowel because it's basically necrosed and dead, and it's just going to cause more problems. We need to resect it and give oral vancomycin or fidaxomicin to cover the problem. And if there's an ileus and you cannot take any oral drugs, you should give IV metronidazole or intracolonic vancomycin because they can't take oral. So if you can't take PO, you get IV or inject directly put into the colon through an enema of vancomycin. Now for our last slide and our sample question. What's the following as the next best step in management? Continue oral metronidazole therapy, stop the metronidazole therapy and prepare for fecal transplant, stop metronidazole therapy and have patient avoid antibiotics, prescribe an antidiarrheal, or stop metronidazole therapy and start oral vanc. So we have a 60-year-old patient admitted to the internal medicine ward for cellulitis with systemic toxicity. So he's a pretty bad cellulitis here. So he's given IV antibiotics and monitored. On day 3, he has multiple episodes of watery diarrhea. So the watery diarrhea is a classic indicator of C. diff. Not previously had this problem, suspects C. diff and orders a PCR, and it's positive. Patient's positive with PCR and has symptoms, and is given oral metronidazole for the mild C. diff. The patient's discharged, but despite the metronidazole, diarrhea does not remit for 2 weeks, so it never resolved. Since it never resolved, there's a treatment failure of metronidazole. He visits his doctor and wants help, and the PCR is still positive. So would we want to repeat metronidazole here? No, definitely not. Metronidazole did not work. But a key thing to remember, though, is that if the diarrhea resolves and they get C. diff again, you can give oral metronidazole the second time. But if it never resolves, you want to give something else other than metronidazole because metronidazole obviously didn't work. So stop metronidazole and prepare for fecal transplant? No, we only do that after multiple recurrences, not after just one. So it's not that. Stop metronidazole therapy and have patient avoid antibiotics. That's not treating the problem, so that won't help either. Do you ever want to give an antidiarrheal medication to C. diff? Definitely not. You don't want to do that because then you'll slow down the GI tract and the C. diff will grow even more and proliferate even more and cause it to be worse. And you do not want to do that and cause worsening of the disease. How about stop metronidazole and start oral vanc? That sounds like a great treatment. You stop the therapy that's not working and try a new one. So this will be our answer here.